All right. Really excited to introduce our first keynote speaker, Dr. Gabby Cordova Ramos. Dr. Ramos is an assistant professor of pediatrics at Boston University School of Medicine and a clinical neonatologist at Boston Medical Center. In her research work, she investigates the impact of social care interventions in the NICU setting to address healthcare inequities in breastfeeding, skin to skin, as well as family engagement. Currently, she leads a multi-site QI initiative targeting social determinants of health in the NICU. Now, that's just what's written here. Let me just say a few personal notes about Gabby. I think Gabby is, she's a junior faculty, but I think she really is, she along with a few other folks across the country is really the future of what health services research and quality improvement at state levels look like for equity and family engagement in the NICU. And I am just so, so happy that she's here with us. She truly talks the talk and walks the walk, serving in her safety net hospital at Boston Medical Center. And she is a very busy person, but always, always makes time and space to share her expertise with us as she is here today. So thank you.
All right. Thank you so much. That was a very kind introduction, and I am really, really happy to be here. And I hope I can talk a little bit about what we're doing and spark a few ideas. So I have nothing to disclose. So I do like to start like this, and I do want to take a brief moment so that you could reflect on your own positionality. So where are you located in relation to your various social identities? I think this is really important because every one of us has their own set of unique experiences of privilege and of discrimination. And those experiences combine to make us who we are and to give us a perspective and an understanding of the world and how we engage with it. So I do want to give you a few of the experiences that shape the lens through which I approach this work, which is that I came to the US as a young adult about a decade ago now, after having completed medical school in Peru. I actually learned English in my 20s, in a very intense way. And for many years, I had a visa and all the problems that come with that. And I'm now a green card holder, so I don't yet vote. I do want us to be on the same page with a few terms that I will use throughout this talk. The first one is disparity and inequity. So of course, you all want to eliminate disparities, and disparities mean a difference of some kind. You want everyone to get the best quality care possible. But whenever I talk about a difference on the basis of language preference, I will use the term inequity. And that is because inequity implies that there's a difference, of course, and that the difference can be unnecessary and avoidable, but it's also unfair and unjust. And there are many terms to talk about non-English speakers. And the most widely used term in academia is limited English proficiency, or LEP. And what you should know about that term is that it was initially coined in the 1970s, and it was intended to provide legal terminology to federally regulate language access. So for all of us working in this space trying to advance language justice for families, there has been a recent and very much needed shift towards non-deficit terminology, which is what I will use today, including preferred languages other than English and non-English language preference. So I really hope that by the end of this time together, you will be able to not only recognize the various levels of barriers that families with languages other than English experience in the NICU, but you will come up with some novel approaches and some ideas that you can put in place to advance language justice. And as a bonus, I do hope that I get you pumped about the power of QI science to advance equity in general. So let's get started. So 1 in 4 Americans speak a language other than English at home, myself included. My husband is American, but I'm trying to raise a bilingual baby now, so we're now speaking Spanish. And what was this proportion, do you think, back in the 1980s? 1 in 10. So that's how much this has changed in just a few decades. And 26 million people speak English less than very well, which is the federal definition for limited English proficiency. And out of this group, 65% speak Spanish, but there are over 300 different languages. And of course, there are lots of mandates and regulations that have evolved over time. The legal foundation for language access services was actually in the Title VI, that's a typo, of the Civil Rights Act in 1964. But it was not until the 2000s that the Office of Minority Health put in place national standards for what culturally and linguistically appropriate services look like. And these standards, which are quite important, were updated in 2013 to give a little bit more guidance to organizations on to how to operationalize them. And so these national class standards are 15. The first one is just a general principle that is very aspirational of providing the best quality care regardless of preferred language and communication needs. But the remaining 14 standards are more specific, and they fall into one of three buckets: either governance, leadership and workforce, communication and language assistance, or engagement, continuous improvement, and accountability. And out of the 15 standards, there are 4, standards 4 to 7, which are considered the most important because they are mandatory for all the federally funded healthcare organizations. So they are tied to money. And most of these, 3 out of these 4, fall within the bucket of communication and language assistance. And they include offering language assistance to all individuals who have limited English proficiency at no cost, informing all individuals of the availability of these services, and ensuring the competency of those who are providing the language assistance. So our group was really interested in understanding how our NICU is doing in relation to class standards. And so we conducted this survey back in 2022. And we surveyed 500 NICUs across 5 US regions. And we got 170 responses. That was pretty hard. But we did learn that despite the long-standing mandates and regulations, only 63% of NICUs reported consistent documentation of caregiver language, and only 41% reported consistent professional interpreter use of any kind, in person or remote, more than 75% of the time for families with preferred languages other than English. And the measures of language that were collected were also highly variable, included preferred language and primary languages as the main ones. And the availability of language services were also quite variable. But we were also interested in understanding how are NICU teams using the various modalities of interpretation during daytime and nights and weekends, which we know in the NICU are quite different scenarios. And so just to guide you a little bit on this figure, on the y-axis, you have the types of modalities of interpretation, and on the x-axis, you have the percent of NICUs that reported using that given modality. And the colors mean the frequency of use, from almost always in blue to almost never in red. So a few takeaways from this figure are that during daytime, despite availability of in-person interpreters, in-person interpretation is relatively underutilized compared to remote modalities of interpretation. And during nights and weekends, not surprisingly, the most commonly reported modes of interpretation are phone followed by video. But also in the yellow bar at the top and bottom, you can see that almost 50% of NICUs reported using ad hoc interpreters, so that includes family, friends, and trained staff, etc., up to 50% of the time. So sometimes, which we define for respondents as 25 to 49% of the time. That's a lot. And there was also interest from our group to understand the degree to which teams used high-quality interpretation, which we defined as in-person interpreter or certified bilingual staff, during the various communication events that happened throughout the NICU hospitalization. And we learned that high-quality interpretation was reportedly used most commonly for family conferences and discharge teaching, and least commonly used for things like daily clinical rounds and regular bedside updates. States, which I'm sure resonates with your own experience. But we also asked clinical leaders' perspectives of what this means, what they think this means for families. So this is from the clinician perspective. And the vast majority agreed that the frequency and the quality of communication for families with languages other than English is different than English-speaking families. But the majority disagreed that this difference leads to different support services or different care quality for the infants. And I will leave you with the question of whether you think this is true. So far we know that the provision of culturally and linguistically appropriate services for families with languages other than English is largely still suboptimal and highly variable. And when there's practice variation, there is always room for improvement. And of course, different interpreter modalities have distinct advantages and disadvantages. And this is not to say that in-person interpretation is the end-all be-all, but rather that the NICU is such a unique environment that changes constantly. The demands of what we need to communicate changes, and the needs of families change over time. So it is possible that a strategic use of the various modalities might optimally address this rapid changing environment. But what does this really mean for families, right? So I do love to present this paper, which is now a little older. It's like 5 years older, but it is from your own group. And I love it because it really illustrates the communication gap. So what this group showed is that Spanish-speaking parents in the NICU receive the majority of their updates in English. That's crazy, right? And of course, this resulted in Spanish-speaking parents being 4 times more likely to incorrectly identify their infant's diagnosis than English-speaking parents. So our group was interested in understanding what does this mean for family engagement. So we conducted some qualitative work. So we interviewed mothers of preterm infants with various preferred languages, including Spanish, Haitian Creole, and Brazilian Portuguese. And we recruited these mothers from three NICUs across 2 states, including Massachusetts and Colorado. And we organized both the themes that came up from this work as well as the recommendations according to the levels of the socio-ecological model. And the reason we did that was so that we could try to understand the various things we can do to address barriers at all these levels. And so in the individual level, one of the main themes was that there is substantial stress that's caused by unaddressed language barriers. And I think the best way to illustrate this is by directly reading these quotes. So this Brazilian Portuguese-speaking mother said, "The lack of information ends up creating monsters within us that don't exist because you don't have enough information. You end up being more worried about simple things. You worry a lot because you didn't know anything about it." And there was a variable degree of empowerment that families had to advocate for language services. So on one hand, this Haitian Creole-speaking mother said, when they were giving me the final instructions to bring him home, I asked for an interpreter to ensure that I understand everything well. Whereas a Spanish-speaking mother, on the other hand, said when they would turn off the screen, and she was talking about the iPad interpreter, maybe something would pop in my head. And I didn't want to bother them or tell the nurse to turn it on again. And I had to leave that question unanswered. And finally, many families, and this was a surprise to our group, just justified suboptimal interpreter use. This Spanish-speaking mother said, sometimes I didn't want to ask for a translator because I knew they also have to care for other babies. So they couldn't be all the time with me and my baby. So I tried to ask things only when it was really necessary. So at the interpersonal level, one of the main things that came up was that families used words like lucky, fortunate, or blessed to talk about language concordance. And in this quote, a Spanish-speaking mother said, I was blessed to have 2 nurses who spoke Spanish, and one of the lactation nurses who spoke Spanish. I love that. I would ask them when they work next to make sure I was there too. And one of the things that we absolutely wanted to highlight today is that many, many families talked about the value of non-interpreted, informal interactions to build trust and to build rapport. And these quotes are great. This Spanish-speaking mom said, some of them spoke very little, but it was always very nice because they were very kind and you could see they cared and they were trying to communicate even if it wasn't perfect. Let's hope that this was in a non-clinical communication setting. This Portuguese-speaking mother said on the other side, this nurse always chit-chatted with me with Google Translate. It was so sweet. We laughed a lot. I taught her a few words. But unfortunately, we also identified instances of differential treatment on the basis of language preference. So these mothers said, sometimes I saw that mothers who speak English get to ask more questions to the nurses. They just talk more with the nurses. And this is very true, right? And finally, at the institutional level, we identified variable quality of interpreter services, and these applied not just to remote modalities of interpretation, which is what we would have thought, it also applied to in-person interpreters. So in this quote, this Haitian Creole-speaking mother said, there are interpreters who are better than others. Some of them communicate better to facilitate understanding. Others just repeat the words. They just don't care whether you understand or not. And of course, there were some systemic barriers to timely access to language services. In this quote, mom said, many times I couldn't get an interpreter or an iPad every day, and many times I had doubts, I had questions, and I couldn't ask them because there was no interpreter available. Unfortunately, this quote came from our own unit, where there is always a remote modality of interpretation available. So this was just a perception that there was none, because they would use it, right, if there was. And finally, many families talked about the utility of multilingual written and audiovisual aids. So this Spanish-speaking mother was talking about learning about safe sleep. And she said, not speaking English didn't affect me much because a lot of these things were shown to me in videos in Spanish that were very clear. And so we generated a few recommendations, starting with families' voices, but also from our own experience. That start with just identifying families' individual communication needs and preferences, and making sure that all families are informed of their right to culturally and linguistically appropriate services. Of course, it will take time to strive for language concordance, because that would have to be through diversification of the workforce. But in the meantime, we can start fostering culturally sensitive care practices in everything we do. And we do believe that there's a very important role, particularly in the emotional roller coaster of the NICU experience, of those non-interpreted informal chit-chats that just make families feel welcome and just supported. And finally, institutionally, it's important to continue to improve the quality, access, and use of interpreter services, and understand when different modalities of interpretation may be best suited for families, whereas it's family conferences, discharge teaching, regular rounds, etc. So it is very clear that there are a number of barriers with regards to communication and engagement for families with languages other than English. But if something sinks in, is that this is so important that it leads families to feel isolated or just delayed and missed opportunities to be involved in their infant's care, and just feeling overall less socially and emotionally supported. But language ability and comfort is quite contextual. While some families may want or need an interpreter for clinical communication, many also communicate conversationally quite well in English. And so understanding when these things have a role in the NICU experience is I think, where we need to move towards. And so for the next part of the talk, I hope that I can bring a few of the examples of the things we instituted in our unit to advance language justice. So this is our driver diagram, and I'm sorry, it's a little small, but I just want to draw attention to our main aim. So our main goal was to increase the percent of families who receive effective and appropriate communication during their infant's NICU hospitalization above 20% from baseline by a year's end. So we started this project in 2021. And as a team, we made the conscious decision of making explicit from the beginning of the project that we wanted to decrease any inequities in communication by language preference that we identified. And our main three drivers were related to suboptimal communication between staff and families, delayed first family meetings, which were particularly delayed for families with languages other than English, and just general underutilization of interpreter services. And so one of the things I'm most proud of for this particular project is that we were able to recruit 4 family partners. So 4 families, and 2 of them were recruited while their babies were still in the NICU, and they were interested in participating. And it was 3 mothers and 1 father. And they were basically the ultimate, like, they were the best. They were just absolutely the best. Every single good idea that I will present next came from them. The okay ideas came from us. So the first cycle was related to just making family communication more visible. So we instituted a bedside card that I'm going to show next, and a family form to be given to families within 2 days of admission. And they were both available in our 3 more common languages, which are English, Spanish, and Haitian Creole. So the family communication form was quite important because it made explicit to families our commitment to improve our communication. And it framed it so that we are asking these questions because we really want to understand your communication needs and preferences. And we want to do that so that we can best support the entire family unit and provide the best possible care. But one of the brilliant ideas that absolutely came from families is the back of the form had some examples of questions. And I recall this mother saying, sometimes the doctors ask you, what questions do you have? And you go blank. And so, especially during high stress moments. And so they just basically broke down a few ideas of questions most parents may wonder and organized them into the big picture, communication, keeping track of information, and going home. So an example of a question was, I've heard the details. You know, we usually say, we advanced the feeds by 30% today. But what is the big picture? You know, when is he going to be able to breastfeed? Things like that. And the laminated bedside card was basically placed at the same time that we put the baby's name on the wall. And it made very explicit that there was a family meeting arranged. And it reminded teams that a family meeting had not been set up yet if it wasn't listed. And it also made explicit families' language preference in a very non-stigmatized way, and also made sure that the team had scheduled the next interpreter update. And then one of our rockstar residents got some funding, and so we were able to do a few additional resources, including some videos from graduate families, which we currently have just in English and Spanish, but we're working on Haitian Creole. And again, a few of the ideas were okay, like the NICU dictionary, which no one ever used. And a few ideas were brilliant, which came from families, like the timelines for babies, just general timelines for younger and older babies. Very simple in a pictorial way. And then this beautiful handout, and you can QR code, you can scan that and check them out. Information to give to family and friends about how to be helpful. And then the welcome videos were just 2 or 3 minute videos that emphasized the empowered families to ask questions as many times as they needed, and to advocate for a family update. And then in our second cycle, because we are a teaching unit where residents carry out a lot of the communication with families, we felt that it was really important to train them in class. And so we actually reached to the residency leadership and adapted an existing curriculum to work with multilingual, multicultural families and working with interpreters. And one of the things we emphasized was the teach back technique. So we taught residents to say things like, I've just said a lot of things. To make sure I did a good job and explained things clearly, can you describe to me? And then we also instituted a way in which residents would document when they provided families with an update and whether they use an interpreter for it or not. Beyond tracking and getting this data, this was just a way of keeping people accountable. Our third cycle was one of the most fun, and we also leveraged people that were really skilled in graphic design. And we did these multilingual written and audiovisual aids, which we are happy to share. We created a few flip charts that were laminated that had pictures that helped us explain complex concepts. For example, this picture here shows what the intestines may look like in neck. And similarly, we had pictures of the back of the eye so that we could explain eye exams and things like that. And then developed multilingual one-page handouts of the 10 more common NICU diagnoses, from respiratory distress syndrome to cooling, including a few things of what it is, what causes it, how common it is, and what treatment is my baby receiving. And every handout included, please ask your team for more information. And then our group was able to secure some funding from the AAP to create multilingual videos. And so what was great about this is we recruited families, and they led the whole thing. They decided what topics we would focus on, and they fully developed the content of the videos. We basically facilitated it happening. And these are 5 videos in English and Spanish, which are currently available on the AAP website, and that's the link. Finally, for our last PDSA cycle, it took months of work, but we were able to improve our remote interpretation services by acquiring one iPad interpreter. To that point, we only had the phone interpreters through a third-party vendor. And what was wonderful about the iPad is it was both for voice and for video interpretation, but it made it so much faster to connect to the interpreter, and the audio quality was so much better. So nurses were particularly excited with this one, and it rolls to someone, and so it lives in a little corner. And then the final brilliant idea that came from families is they told us that one of the points of pain is calling the NICU. So not just when you are in the NICU, but when you call. They were not able to get an update in their language. And so we basically work with interpreter services in a way that when families call the NICU, we could easily conference in someone. And so we put these laminated cards on all unit phones, and families really loved it. And the nurses found it fine, easy to use. And so out of all the things we measured, one of the things we felt was really important was for our measures of family communication to be parent-reported. So we created this family experience questionnaire, again in 3 languages. And this questionnaire was given to families at this church. And they were invited but not obligated to fill it out. And so, again, they said, we are working to improve our communication about your baby. Your medical team will not see these responses. So that was important for us. So they put it in a little sealed envelope. And so this is how we define quality of communication and effectiveness of communication. Quality of communication was defined by agree or strongly agree to these 4 statements. I was asked about my concerns. I was asked about my goals. I was able to ask all the questions. The team explained how I could participate, and the team was respectful and sensitive to our customs and values. I don't know how to count. That was 5, sorry. And the effective communication was taken from the work that was done here by cross-referencing what the parents reported was the reason their baby was hospitalized to what the residents named as a diagnosis on the back of that sealed envelope. And then for families with languages other than English, we also added a few other questions of whether an interpreter was used for the various clinical touch points and how they received their communication updates from nurses and doctors. And so these are a few of the results. So in terms of quality of communication, at baseline, we learned that 79% of non-English speaking families and 86% of English speaking families, like I said, agree or strongly agree to all those statements. So there was a gap. Throughout the project period, we were able to increase that to 95% and 97%. So virtually eliminating that quality of communication gap. In terms of correct infant diagnosis, we were actually surprised to see that only about half of non-English speaking families and about 2/3 of English speaking families correctly identified their infant diagnosis. By the end of the project period, this increased to 81 and 87%, reducing but not quite eliminating the gap. And finally, for the time to the first family meeting, we saw that it went from a median of 10 for English-speaking families and 15 for non-English-speaking families, to about a week for both of them. Our group was quite surprised to see that some families went 2 weeks without an update, a formal update, of course. And finally, I do want to remind you that it's not just about language barriers, and I think Susan talked a little bit about this when she was presenting the data. But there is this very important concept of intersectionality. So in the US, families with preferred languages other than English often have other social disadvantages. And if you think about it, communication difficulties can really be compounded by lower educational attainment on just limited financial resources or vulnerability of unclear immigration status. And so when we approach projects that try to reduce inequities for this group, we have to think about all those intersecting factors. So I will, as the last part of this talk, I will just show you one of our projects that tackled breastfeeding continuation, which I think tries to illustrate this point. In Massachusetts, and this is probably true from other states, but not necessarily all states, matters of premature infants, Spanish-speaking Latina matters of premature infants have the earliest breastfeeding discontinuation. So we tried to understand as a group why that is happening. And so we did I do love qualitative work, as you can tell. We did some more qualitative work to try to understand why this is happening. And we used the theory of planned behavior. So the theory of planned behavior is just a framework that allows you to understand what drives behavior, in this case, breastfeeding. And what it posits is that the intention to do the behavior, in this case, breastfeed, is highly influenced by your attitudes towards the behavior, but the subjective norms, so what you think others think about the behavior, but your own perceived ability to complete the behavior. And so while we identified themes for all of those, the most salient theme was within the perceived control domain. So what families said was that unmet social needs really contribute to breastfeeding discontinuation in two main ways. One, it made it logistically difficult to be present in the NICU as much as they wanted, for difficulties with having to go back to work, lacking transportation, not having childcare, etc. But on the other hand, it also caused a substantial stress and worry that they directly linked to ceasing efforts to pump, and just like decreasing milk supply in general. And so the intervention that we created, that was possible thanks to an institutional grant, was instituted a dual model of breastfeeding peer counseling and social needs navigation. And what this means is, in this model, a peer counselor, so a former parent with breastfeeding experience, received training in breastfeeding counseling and in NICU-specific lactation support, and was also trained to conduct social needs screening, refer families to resources, and provide hands-on assistance through longitudinal navigation services to actually connect with the needed resources. So things like filling out application, calling agencies, gathering documents, things like that, because the role was exclusively designed to do that. And this person was very heavily integrated into the multidisciplinary NICU team and mentored and worked collaboratively with the social worker and the lactation consultant. Because we knew how important language barriers were and cultural aspects related to breastfeeding were, we wanted to hire 2 part-time counselors who would be able to assist families who speak English, Spanish, and Haitian Creole. And we were lucky enough to identify an individual who was trilingual. So we ended up just hiring her. And what we hypothesized would happen is that these combined strategies of peer breastfeeding counseling and social needs screening and navigation would lead to more breastfeeding duration because there will be some trusted peer support and activation of resource connection that would reduce caregivers' stress related to unmet social needs and address barriers to caregivers being present in the NICU. And when they were being present in the NICU, they would be able to access culturally competent language concordant lactation support. We also wanted to make sure that the model was implemented equitably. So we tracked the number of families that met with the navigator at least twice by race, ethnicity, and primary language. And if anything, then the counselor met a little bit more, but not statistically significant with non-English families and non-Hispanic Black families. And the model was so successful. We had an increase of 21 percentage points of any breastfeeding at discharge of transfer pre and post intervention. That this model's grant expired in 2022, and it was incorporated into the hospital's budget to make it sustainable. So when we went back to families to try to understand what aspects of the model matter the most to them, language concordance and the culturally sensitive lactation support was an absolutely core component of the intervention. And we learned that to advance equity, it's not enough to tackle the individual level barriers, which is things like educating families on how important it is to breastfeed. But rather, we had to think about ways to address structural barriers, which in our case were increasing our capacity to provide lactation support, and socioeconomic barriers, for example, alleviating transportation barriers so that families could be in the NICU while they receive the intervention. So I think I went a little faster than I thought I would, but this is my second to last slide. I call it a conclusion, but I hope it's more of a calling. I want you to remember that language is fundamental to our human ability to construct and convey meaning, to interact with others, to articulate our preferences and needs. And all of that is important in everything we do, but is particularly critical to the NICU experience. And improving our language services is not just a tool that's intended to benefit families. It is a tool that is intended to enable us clinicians and any other support roles to effectively care for the families we serve. So QI is a particularly powerful tool to advance equity in the NICU, and I urge you all to try to prioritize language justice as part of any initiative in your commitment to high-quality, equitable NICU care. I do have a lot of people to thank, but I highlighted the 4 family partners that made this possible, along with some rockstar residents there. And a lot of this work was possible thank you to a small grant money. Like the Alpert grant is $10,000. The Lovejoy resident grant was just $5,000. And the bigger one, the intervention for breastfeeding counseling, that was $100,000. But in general, a small money goes a long way. And I currently have an 11-month-old, but this is when she was 6 months. So I'm happy to take any questions.
Hear from Dr. Nick Turner and give a mic right behind you.
Great. I mean, you sounded good, girl. So up to you. Thank you so much, Dr. Cordova Ramos. I wanted to know for your specific projects, to what extent did you actually partner with language services at your hospital versus just saying, here's what we need and we have funding for it?
That's an excellent question. We are blessed with a really involved interpreter services, and the head of interpreter services participates pretty much on various QI initiatives for various departments. So she was part of our QI team.
Thank you so much. I'm curious what you tell healthcare providers that still say this takes a lot of time, right? Everyone is stressed in the NICU. Our censuses are higher, our acuity is higher, and undoubtedly this takes time. And are there ways that you found success in overcoming that barrier to the clinical stress and time that everyone feels pressured in the unit?
Yeah, I think that's a great question. One thing that helped was sharing the qualitative work back with our group, because a lot of these quotes came from our own unit. So people actually, like, it resonated with what they were seeing every day. So that was one thing. And the other thing was asking them for ideas. And so, for example, our unit is small, it's 20 beds, and we have one attending at a time. So you can tell that when things get complicated, carrying a family meeting is difficult. And so we came up with ways in which we have scripts for residents to lead the family meeting for less complicated babies, so that the attending could be freed up to do other things at the time. And so things would still happen, and they were like standardized, but it would follow on, the responsibility would be shared amongst the team.
I'll just comment on Steph's question because I have big thoughts about that. I would say, if the social norm, the expectation is that families are communicated with in a consistent way, and perhaps it's tied to financial incentive, meaning that that hospital day can't be considered billable unless something like this happens, then all of a sudden you see a dramatic change in the social norm of what a clinician's day-to-day responsibilities should be. And then if we take a step further and say, then clinicians say, well, I need to have fewer patients on my list. If this is now the expectation, then you go further down and the hospital says, well, then our staffing model has to change. If, we can't bill for hospital services and the physician billing isn't possible unless this actually happens, then I think you see a very different kind of movement in our field. So that's just sort of my pipe dream. Other questions? I have a question. I thought it was super interesting that you engaged families during their NICU stay to participate in these quality improvement efforts. Typically we say, oh, we give families like 6 to 12 months post-discharge to kind of let them recover from the trauma of being in the NICU to engage in these sorts of things. So curious to know how you are doing this and what your experience has been.
So this wasn't true for all QI efforts, but for this one in particular, it actually happened organically. We had an issue where communication was a problem. And this family pretty much fired one attending because things weren't clear and things like that. And we actually invited this parent after things cool off, but the baby was still admitted and just kind of like in the feeding and growing stage, to just use a little bit of the time that she was at bedside to be part of this effort to improve communication so that things won't happen. She had that personal motivation of what had happened to her to be involved. And she talked to a second mom who was her friend in the unit, and they both participated, kind of reviewing materials, giving feedback. And the things that we would ask them to do was kind of this is the family experience questionnaire we have. Would you be able to read through it and tell us what you would change and what questions you would take out and things you would rephrase and things like that? And they were wonderful.
That's amazing. Clearly, they were really special people to think even beyond outside of their own experience and think how they can improve the experience of others.
Yeah. In general, though, we do try to engage families after NICU discharge because of just the bandwidth to engage with these things. So that as a general rule, we do try to do it post-discharge. This particular thing just happened.
I think we have a virtual question.
We have a question from the virtual audience asking, how did you define family engagement in this study?
Oh, that's great. That's a great question. Very similarly to the AI definition that Susan presented earlier. So kind of ability of the family to communicate clearly with their NICU staff and participate in their infant's care through skin-to-skin breastfeeding, just hands-on care. So a lot of the questions in that study were related to breastfeeding support, safe sleep, and just general communication.
One more question. You know, clearly you're improving things for our minoritized families in the NICU, but do you still find that there's a persistent disparity or inequity in these related outcomes for families who are at the bedside versus those who can't be at the bedside?
1,000%. The best example is rounds. I don't think we can ever, we tried and we actually failed to try to do remote conferences with families who were not at the bedside to try to round with them with an interpreter. It was just like logistically very challenging. And we did it for a week and we abandoned it. And so actually working with breaking transportation barriers, and that's where the issue of intersectionality is so important. Transportation barriers were huge. And so just by providing transportation assistance, we were able to have that many more families at the bedside in order to improve communication and other things.
Wonderful. Thank you, Gabby.
Thanks.